Good afternoon or good evening to everyone who is watching us across Europe. I'm Mine Dursutan-Röver. I'm a professor of internal medicine in Hacettepe University Faculty of Medicine. I have worked as the consultant of the acute care unit for several years and also served as the quality coordinator of my university hospital. And I'm honored to be a member and fellow of and serving for the European Federation of Internal Medicine since 2003. Where I have started this journey as a young internist. So we all have been facing the truth of the pandemic for nearly a year by now, and it has been a unique year with so many challenges in our personal and family lives, as well as in our professional lives. As internists and intensivists, we are the ones at the front lines, and we have been struggling to keep our patients, our colleagues, ourselves, and our families safe while trying to still offer a high quality care despite all of the difficulties. So today we would like to discuss the important quality and patient safety issues, focusing on the risks and the chances for the safety of the patients and healthcare providers during the COVID-19 pandemic. And please don't forget that where there is a risk, there is also a chance for improvement. So today it's my pleasure to chair this webinar together with my colleague, Matthias Raspe, who is still a young internist. He is an internist and pneumologist at the Department for Infectious Diseases and Pneumonology at the Charité University Hospital in Berlin, Germany. He is the head of the German Young Internists Group within the German Society of Internal Medicine, and he actively participates in EFIM working groups since several years. He has been working in lung cancer, but his area of interest includes medical education and specialty training, working conditions of young physicians and nurses, as well as quality of care and patient safety related issues. We are together with Matthias, are the members of the Quality of Care and Professional Issues Subcommittee of EFIM, chaired by Professor Luis Campos, who will be speaking as the first speaker in this webinar. So we today have 4 privileged speakers, but before handing over the microphone to them, I would like to ask Matthias to brief us about today's program and how we will use the question and answer buttons in the webinar. Matthias?
Hello, everybody. My name is Matthias Raspe. Mine, thank you very much for your kind introduction. It's an honor to be here tonight as a moderator in this webinar. I just wanted to keep or to start with a few housekeeping things. As the audience, you're not able to share your screens and microphone. As the panelists you are, and I would ask all the panelists to switch out your microphone and screen during the other one is presenting. Your participation for all the audience is very welcome tonight, and we want to have a lively discussion in the end. And I would ask you to post your questions whenever you want to via the Q&A button, which is on the right down on your screen. And yeah, just write down your questions and we will collect them and go through all questions in the end of the talks. The structure is as follows. We will have 4 talks, one after the other, with no time for discussion between the talks, but we want to move the whole discussion to the end, and we will have enough time in the end to answer all questions. So please, once again, be encouraged to answer your questions whenever you wish. And now I would like to hand over Mine for you to introduce the first speaker.
Yeah, thank you, Matthias. So it's my privilege to introduce you Professor Luis Campos from Portugal. He's the director of the Internal Medicine Department of San Francisco Xavier Hospital in Lisbon, advisor of the General Directorate of Health, member of the Advisory Council of the National Health Plan, and member of the National Committee for Reference Centers. And among his former responsibilities, he was the president of the Portuguese Society of Internal Medicine, president of the National Council for Quality in Healthcare, national coordinator of the Electronic Health Record, director of the Emergency Department of the Western area of Lisbon, and advisor of Macau government and Azores regional government in the area of health. So Today, Luis will be talking about the determinants of quality and patient safety in healthcare, and we are really very glad to hear his experience in this field. So I would like to welcome Luis and hand over the microphone to him. Luis?
Hello, everyone. It's a pleasure to be here, and I will start to share my presentation. So my topic is about the determinants of quality and patient safety in healthcare during the pandemic. And the first thing is that this pandemic was not unexpected because environmental degradation and loss of biodiversity have increased the risk of a pandemic, particularly over the past 2 decades. And the hospitals and healthcare systems should have been prepared for it, as well as we have to be prepared for the appearance of a new pandemic. I was director of the emergency of Western Lisbon in 2003 when we had the SARS threat. After that, we had several threats of pandemics, and there are other potential virus candidates to unleash a new pandemic, like the Nipah virus or Marburg virus or Ebola. The shocking fact is that preventing this pandemic would cost 500 times less than the price we are raising in response to this pandemic. So the topics that I will approach is introduction to the concepts. I will speak about health financing, human resources, hospital structure and equipments, organizational structure, health network, and outcomes. The quality can be analyzed in different dimensions. Our Portuguese health plan adopted 10 different dimensions: effectiveness, efficiency, access, safety, equity, adequacy, opportunity, patient-centered care, continuity, and respect. The quality is dependent of different levels of responsibility, of the system, of the organization, of the unit, of the team, and then also of the individual professional. It is also dependent of the classic division introduced by Donabedian, the structures, that is the set of attributes of the places where healthcare is provided, like buildings, equipment, human resources, financing, organizational structure, processes, how the care is organized and received, and outcomes, the effect of the care in the health of the patients and of the populations. Which are the main determinants of healthcare quality? Well, socioeconomic factors, environmental factors, the healthcare policy, the regulation, but also the characteristics of the systems, the units, the providers, and how they deliver care. And also the characteristics of the community, the family, the patients, and how they implement care. The fact is that the pandemic uncovered the weaknesses of our health systems. And that is about what I will speak. And I will start with the health financing. This is the graphic where we can see that life expectancy on the vertical line at birth is related with the health expenditure per capita on the horizontal line. The richer the countries, the greater the life expectancy and the health of the people. Many of the countries in Europe slowed down the investment in health between 2008 and 2013. And there were even 10 countries that reduced their health spending. And this divestment was particularly in public health systems, which have become increasingly fragile. And this has been a major issue in our ability or inability to respond to this pandemic. However, with COVID pandemic, there seems to be no apparent relationship between the health expenditure per capita and number of deaths. Countries with a high expenditure per capita like France, Belgium, and Norway were also, and Sweden were also countries with a high rate of death by COVID, which means that there are other factors that played a role in mortality attributed to SARS-CoV-2 infection. There has also been no relationship between mortality from COVID and government spending in responding to this pandemic. The 6 European countries with the mortality rate by COVID were like United Kingdom, Spain, France, Italy, and Sweden, and also Belgium. Human resources. The scarcity of human resources in hospitals compromises the ability to respond to unexpected events as it is happening in the response to this pandemic. Practicing doctors between 2000 and 2018, the number of doctors grew in almost all European countries. However, there is an important variation in European countries, and 3 countries with the highest COVID infection rate have a number of practicing doctors well below the European average, namely France, Belgium, and the United Kingdom. Internal medicine has been at the forefront of the fight against the pandemic in most of the countries and has proven its importance in the hospital organization because of its versatility, of its efficiency, its multipotentiality, and its capacity of coordination. In a report of the NHS called the Future Doctor Program that came out in September 2020, Professor Wendy Reid, the CEO of Health Education England, wrote that the pandemic highlighted the importance of managing multimorbidity. And we have to make a fundamental shift in the medical education from a system that places disproportionate value on specialism to one that recognizes crucial value in a generalist training. In a report of the Association of American Medical Colleges published in June 2020 about the physician demand to care old patients, hospitalists were the specialists whose demand will grow most until 2033. But it's not only the number of professionals, it's also their mood, the exhaustion, the lack of motivation, and the lack of compensation. We have been treating COVID patients for 10 months, and now we are being asked for another huge effort. This is an issue that must be addressed. In a report of Amnesty International published in July 2020, several problems related with health professions caring of COVID patients were denounced. Shortage of PPE, unfair payment, lack of compensation in cases of occupational illness, increased workload and mental health concerns, retaliations to workers who complain, and stigma and violence against health workers. And what about the hospital structure and equipment? Well, in all European countries, the number of hospital beds has progressively decreased between 2000 and 2018. And this reduced their ability to respond to unexpected events like this pandemic. 4 of the countries with the highest COVID infection rate had a number of hospital beds before the pandemic well below the European average, namely Italy, Spain, Sweden, and United Kingdom. Also, before the pandemic, the intensive care capacity varied between 34 beds per 100,000 population in Germany and 5 beds in Ireland. Again, 2 of the countries with the highest COVID infection rate have a number of intensive care beds well below the European average, namely United Kingdom, Spain, and Italy. Most of the hospitals were not designed to accommodate this sharp increase in demand and did not obey these principles of hospital design. Prepared for health emergencies, separation of acute and programmed patients, safe, scalable, convertible, multifunctional, connected, and with virtual health technology. This was not the case in the countries most threatened by conflicts or catastrophes. For instance, the hospital Rambam in Haifa, Israel, can increase in 2000 the number of beds converting the underground parking. Hospital design can maximize infection control and preserve scheduled activity, like with individual rooms and facilities dedicated to elective care. But also equipments. In many hospitals, there was a lack of PPE, ventilators, negative pressure machines, and automatic activation of doors, taps, and other equipment. And also many hospitals did not have a digital infrastructure to support telemedicine, education, and training. And what about organizational structure? Well, the hospitals are fragmented in services according to organs or systems. And if this was already an inadequate model to treat our elderly patients with multimorbidity, this silent structure proved to be even more inadequate in responding to this pandemic. A hospital with a more matrix-based and less vertical organization is more flexible to respond to these types of patients and also to respond to important variations in demand. This is something that is happening in several hospitals like Karolinska, Maastricht, Hospital Clinic in Barcelona. Karolinska, for instance, implemented 7 departments: aging, cancer, children and women health, heart and vascular inflammation and infection, neuro and trauma. Home hospitalization demonstrated its importance as an alternative to conventional hospitalization during the pandemic. It prevents patients of advanced age from staying in the hospital rooms in an adverse environment and offers them more satisfaction and also to their families. And what about health network? Well, hospitals are not articulated with primary care or long-term care, neither with social assistance. And this lack of mechanism of coordination and communication was very evident in the management of the response to this pandemic. And problems of communication are the first cause of sentinel events. In reality, if primary care does not collaborate in decreasing the influx of the emergencies and alternatives are not found for 20% of the cases of COVID patients that are hospitalized only because they are unable to quarantine at home, hospitals will not be able to settle down more this pandemic. The integration of care and different levels of assistance would have greatly facilitated the response to this pandemic, including the integrated management of health and social assistance. And finally, outcomes. Reported COVID-19 deaths per million population age 60 or 65 in Europe until the end of October 2020 varied between around 4,000 and 300 per million, and for 149 in Slovak Republic. The 4,000 is in Belgium. But also the pandemic uncovered the healthcare disparities. In the US, Black people are dying 2.2 times the rate of white people. It resulted in excess of mortality in which death by COVID represents only a minor part. This graphic represents the excess mortality in 28 OECD countries over a 10-week period during the pandemic. On vertical axis is the percentage of COVID reported death. On the horizontal axis, the excess death by other causes. The health workers were among the biggest victims of this infection. In May, in Spain, there were already more than 30,000 healthcare workers infected. In September, Mexico had 1,320 health workers death, United States 1,077, and United Kingdom 649. Professor Reinhard will speak about this. Despite all the care, nosocomial COVID infection has been a serious problem. Currently, 17.6% of COVID infections in England are probable healthcare-associated infections. These rates have been as high as 25% in Northwest and continue to climb in the Northeast and Yorkshire. Dr. Marco will speak about this. And I will conclude with this quote from an American poet, Theodore Rothko, that said, "In a dark time, the eye begins to see." So my wish is that we all learn the lessons from this pandemic to change what has to be changed. Thank you.
Delta, could you please close the presentation of Luis Campos? Luis, thank you very much for your brilliant talk. As I told in the beginning, we will discuss in the end, so please keep on asking questions. I want to introduce the next speaker, who is Professor Reinhard Stramitz. He is an anesthesiologist and economist from Germany. He works and teaches at the Rhein-Main University of Applied Sciences in Wiesbaden, which is close to Frankfurt in Germany. And he is chair of the European Researchers Network, which is working on the second victim phenomenon, and is the general secretary of the German Coalition for Patient Safety, a very big a society who cares or which cares for patient safety and is very well known. And your research focus is on the second victim phenomenon, and we are very much looking forward to your talk tonight, which is on which risks are healthcare professionals exposed to. Reinhard, the stage is yours.
Thank you, Matthias, for your kind introduction. It's a pleasure and honor to be here. A warm welcome from Frankfurt, Germany, a city which perceives itself as the center of Europe. I hope you don't mind if we claim this title for Frankfurt. So I will talk about the topic, which risks are health professionals exposed to, of course, with a focus on the COVID-19 pandemic, which revealed the weaknesses of the healthcare systems, as Luis brilliantly pointed already out. So if you look at the exposure of risks during COVID-19, it is evident for everybody, not only healthcare professionals, that they have been exposed to an increased risk of the COVID-19 infection. I will talk about this, and I will give you some numbers to underline what Luis Campos already said about this phenomenon. But as always, if you look at problems, there's an iceberg with some problems that slowly will be revealed when you get close to this iceberg. And as the COVID pandemic revealed weaknesses, we also are now more and more able to talk publicly about other phenomena like the burnout and the chronic fatigue that everybody treating and caring patients for 10 months under this special circumstances now faces, but also about the second victim traumatization. So as Monica will point out, the burnout phenomenon related to COVID-19, we discussed that I will specialize on the second victim traumatization, give a brief introduction, and would like to take this problem in contrast to the COVID-19 pandemic. Before this, of course, if there's an elephant in the room, you have to introduce him. Of course, it is an increased risk for healthcare professionals. So the latest publication I was aware of is some research from the United Kingdom, which suffers a lot of deaths among healthcare professionals. And a cohort study of the UK Biobank reveals that healthcare workers have a sevenfold higher risk in the United Kingdom to get a severe COVID-19 infection, not only a asymptomatic COVID-19 infection. And medical support staff who's had the highest risk among all occupational groups to be infected and to have a severe COVID-19 infection, which unfortunately resulted in many, many deaths all around the world. So, of course, it is mandatory to have sufficient PPE so that you have enough PPE and that those masks, for example, you're using, that face shields you're using have been certified and do not lack of quality. So one take-home message, Germany is already taken, and I think it is take-home message all across Europe, is that we cannot simply and solely rely on one source of PPE supplying system, because if supply chains will break down, which they did during the first wave of the COVID-19 pandemic, you don't have any capacity to reinstall these PPE. So what Germany has learned about this is that there are 19 secret places where PPE will be stored after COVID-19, that it can be easily accessible for all healthcare professionals in the next pandemic, which will be only a matter of time and not a matter if it will happen. So on the other hand, there's a problem that already existed long before COVID-19, but the weakness is now revealed publicly. And it's the point that patient safety, which is one of my research topics, is closely related, or as I would say, is part of health worker safety. So you all know about patients who are harmed by unanticipated clinical events and their next of kind, their relatives, who are called first victims. And in 2000, Albert Wu introduced the term of a second victim, meaning a healthcare professional, first of all, that has made a medical error that will traumatize the healthcare professional itself. This term was later broadened, and now a second victim refers to a healthcare team member of any kind of profession involved in an anticipated patient event, whether it is a medical error or a patient-related injury or any other unanticipated event. And I think it's obvious and evident that you can call the COVID-19 pandemic and the circumstances for healthcare as an unanticipated, relevant clinical event that traumatizes healthcare professionals. Also, we are talking about third victims, meaning healthcare organizations, or during the COVID-19 pandemic, even healthcare systems that had to limit their capacities and they ran out of capacity to maintain the goals of quality of healthcare, as Luis has pointed out. So there were lots of people all across Europe who didn't gain access to the medical treatment that was in need, referring to other problems as COVID-19. If you look at the cancer patients or the numbers of patients with heart attacks or strokes that were admitted to hospitals, which also led to an increased mortality all across Europe. So patient safety is health worker safety, and it's a relevant problem. So long after Albert Wu published this second victim term, there was a lot of research done, which was not regarded very much until the COVID-19 pandemic, to show that this is a systematic problem that long existed. So Recent systematic reviews, also recent studies Matthias Rasper and I conducted in Germany, show that up to 50% of healthcare professionals, doctors as well as nurses, report to have been second victims on their own within the last 3 years. And experts assume that every healthcare professional will be second victim at least once during his or her medical career. So it's a problem we are all facing. And some of us will recover very fast. But up to 20% of second victims in surveys report that they have not fully recovered from their key incidents within years, or they didn't fully recover at all. So there are a lot of healthcare professionals who have a need for support if they are second victims. For example, if you do a medical error, most of the times, the second victim itself is the person who punishes itself the most, as we know from several cases that were analyzed in the course of a second victim phenomenon and traumatization. So if you look at some early research from Amy Waterman and colleagues, which was already published in 2007, you see that serious errors as well as near misses can cause an increased anxiety about future errors. And it is evident and is well researched that if you do something under anxiety, which is a main problem, as already pointed out, the likelihood of medical error increases dramatically. And you all know this from your own personal experience. If you do something in anxiety, the risk of making drastic failures is increased a couple of times. So it's mainly the risk of future errors and the anxiety about future errors and the loss of job satisfaction and self-confidence in your job that will cause problems to a lot of medical healthcare professionals, and that has caused this harm in the last decades and centuries, I guess, long before COVID-19 existed. In 2007, in the United States, only 10% of the responders of this survey responded that they got emotional support, psychological support from their organization, a number which has increased by now due to increased support programs that were established in the United States, like the RISE program at Johns Hopkins University or the For You program at the University of Missouri, for example. So in the United States, there's in some centers, there's an advanced support program showing medical benefits as well as a cost effectiveness. So if you don't help second victims, 2/3 of all second victims will develop dysfunctional coping strategies like isolation or depression, which can also lead to post-traumatic stress disorder. Abuse of substances will increase dramatically. Also defensive medicine, which will result in more patient harm and increase in healthcare expenditures that do not provide any positive medical outcome. And there are a lot of colleagues, a lot of people I know that also turned over from their profession. And this is not a matter of experience in your professional career. So there are also some people with a medical career of 20 years who had to turn over because of a second victim traumatization. And the most dark side of all this is that second victim traumatization also leads to an increased risk of suicide, which is also evident among healthcare professionals in some disciplines to have a up to 8-fold increased risk of committing suicide. And you all know the dramatic news from the Bergamo region, from Spain or from New York, that there were healthcare professionals who weren't able to cope with the situation and who committed suicide. So second victims don't need punishment. They are mostly best of it to punish themselves. They need support. And what can be done? The German Coalition for Patient Safety and the Austrian Platform Patient Safety teamed up. So there was a research cooperation from Austria and Germany. And on Easter weekend, we published a recommendation for maintaining capacity in the healthcare systems during the COVID-19 pandemic, as we in Germany, which is very well equipped with intensive care unit beds and medical equipment, also recognized that there is a lack of emotional support and a lack of resilience amongst healthcare workers. Even in a prosperous country like Germany, we have a system that is constantly decreasing its resources and is nearly running on and nearly ran on the edge just before COVID-19. So we teamed up and we developed a recommendation how to maintain capacity, also reinforcing clinicians' resilience by means of leadership that is focused on resilience. So a clear and optimistic vision, a realistic plan, a crisis communication that is up to date and then talks about and gives up-to-date information on the effects of the pandemic, as well as guidance for self-help, as we are all not very good in caring for ourselves instead of caring for our patients. And the continuous support of staff, which is still necessary and needed more than ever after 10 months of exhausting treatment of COVID-19 patients. So the pandemic isn't over, you all know this, and we have to sensitize our political leaders as well as our leaders of the healthcare system that this pandemic is not over and that we are entering a very crucial phase of this pandemic right now, as most of the staff who can treat, who is able to treat COVID-19 patients faces long-term fatigue and burnout. So is there a light at the end of the tunnel? I think there is. Looking at the second victim phenomenon, the European Researchers Network working on second victims, which is my pleasure to have the vice chair together with Jose Mira from Spain, who is chair of this action, has teamed up in September 2020. It's an EU coast action with 29 countries who will address this phenomenon on multiple levels, starting from the legal system, that healthcare workers might have a legal right to get second victim support, like in the train section or the commercial aviation sector, so that we get the equal rights for second victim support in the healthcare sector as well, up to local initiatives and national initiatives to raise awareness for these problems and to implement the solutions, the evidence-based solutions that are already in place. So I think there's a light at the end of the tunnel, but being an anesthetologist and a risk manager, if there is a light at the end of the tunnel, please double check that it's not a train arriving. So, but I hope this problem will be addressed on the European level, so that we take the chance and the opportunity to learn from this problem that already has existed long before COVID-19 and that will exist long after COVID-19 to help healthcare workers coping with the situation. So this does not stop the pandemic, but if the pandemic is still occurring, you have to be as resilient as it gets. So my core messages are: health worker safety is patient safety, and investing in health worker safety is also a huge investment in patient safety. Second victims need support instead of additional punishment, and they have to have the chance to reveal their traumatization. Not to say that they are heroes and that they have to be strong, but to admit that they have a problem as a sign of responsibility, not as a sign of weakness. And third, to focus on resilience of healthcare professionals is essential and is a very, very smart investment before, during, because of, and after the COVID-19 pandemic. So thank you very much for listening to me, and I'm looking forward to the discussion.
Reinhard, thanks a lot. It's always a pleasure to listen to you. So this is a very critical and hot topic you mentioned. So there are some questions that we can discuss at the very end. And now I would like to introduce my friend, Dr. Monica Bivol, from Norway. She is a specialist in internal medicine and consultant in nephrology. And she is a fellow researcher, holds a PhD degree in basic research on renovascular hypertension. And she has a special interest on inflammation in renal diseases. So she worked for University of Bergen, University of Tromsø and University of Oslo, and she served as the associate editor for European Journal of Internal Medicine for a long time. and representing the Norwegian Society of Internal Medicine in EFIM. She is the founder member of Young Norwegian Internist Society and also a member of the Quality of Care and Professional Issues Subcommittee of EFIM. So we have been friends for a long time by now, and now it's my privilege to give the microphone to Monica. So Monica, the stage is yours.
Good evening, everybody, and thank you very much, Mina, for your introduction. I invite you all to follow the next presentation, which is about burnout. I think I have some problems to control my own presentation, so I don't know why I cannot continue now. It's good. Thank you all. So about burnout of healthcare providers. And we know that COVID-19 outbreak has shaken the world and changed the rules globally since December 2019. And the epidemic's impact of COVID-19 pandemic on our civilization was compared to that of World War II. With more than 200 countries affected, over 86 million confirmed cases, more than 1.8 million deaths globally since December 2019. The COVID-19 pandemic put approximately 3 billion people in lockdown and has emerged as an unprecedented healthcare crisis. My presentation will try to point out the following moments. To define shortly the burnout, as you already heard about from Reinhard's presentation. To learn about the main stressors that could lead the burnout of healthcare providers. To underline few healthcare ethical aspects. And at the end, to underline few potential strategies for burnout. Previous pandemic, as we already learned, involving quarantine, have shown that healthcare professionals are presenting symptoms of post-traumatic stress disease or anxiety or depression, insomnia or substance use disorders, as you already learned from Reinhard's presentation. The coronavirus pandemic disease, COVID-19, can lead to a lot of different challenges to an underprepared healthcare system, and we all already experienced this. And healthcare providers all worldwide are facing acute working stress that lead, of course, to a high rate of physicians' burnout. And what is actually burnout? The term appeared first in 1970s and was defined by Herbert Freudenberg. He said that burnout would be a state of emotional, physical, and mental exhaustion caused by excessive and prolonged stress. Occurs when we are overwhelmed, when we are emotionally drained, when we are unable to meet constant demands at work. In November 2019, ironically, World Health Organization redefined burnout and completed the definition of burnout, which is actually a synonym with professional exhaustion. So burnout is a syndrome as a result of chronic stress at work that has not been properly managed. A feeling of low energy, exhaustion, feelings of negativity, loss of professional efficiency or interest. Which are the stressors that are leading to burnout of healthcare professionals? I could not help myself, and Reinhard already mentioned about this. I could not help to present these stressors during COVID-19 other than to tell you shortly the story of Dr. Lorna Breen. That was published in August 2020 by Jennifer Feast. Who was Dr. Lorna Breen? She was the head of the emergency department at New York Presbyterian Allen Hospital. Within a period of 3 weeks, she had treated confirmed 19. She contracted COVID-19 herself and then returned to an overwhelming number of incredibly sick patients. Dr. Breen worked around the clock during the COVID-19 outbreak in New York with limited personnel, limited protective equipment, insufficient supplies, not enough oxygen, not enough beds, not enough help. And she saw patients dying in the waiting room. After 12 hours shift, Dr. Breen would stay at work because the high number of patients in need. And when she left the emergency department, she would normally take the train home, but as the trains were almost empty due to distancing measures, she was afraid of being mugged. She tried to take cabs home instead, but some of the cabs that stopped wouldn't pick up someone leaving the hospital for fear of being exposed to the virus. In spite of that, she kept going back to work until she literally could no longer stand. On April 9, Lorna was nearly catatonic. She had not slept in over a week. During one shift, she covered 2 emergency rooms in Manhattan at the same time, at locations that are 5 miles apart. Dr. Lorna Breen had answered the call for her city and for her country. And when she became so overworked and she was unable to move, what was her biggest fear? Her job. Dr. Breen was worried that she would lose her medical license. She will be ostracized by her colleagues because she was suffering due to her work on the front lines of COVID-19 pandemic health crisis. Dr. Breen died by suicide on April 26, 2020. She had no prior history of mental health issues, but when she experienced a mental health crisis for the first time during the pandemic, she was afraid to get help. She was worried it would end the career that she had spent her entire life working for. In this article published in September 2020, the report says that COVID-19 has killed more than 1,700 healthcare workers, but the number today is much, much higher. In memory of all our colleagues that lost their lives during COVID-19 pandemic, let's take a moment of silence. And let's go further to learn which are the stressors in pandemic, having the story of Dr. Lorna Breen in your mind. I pointed out few literature that are listed at the bottom of the slides in the next 3 slides. And one of the principal stressor when it's about burnout connected with this COVID-19 pandemic would be the fear of being infected or infect your own family because you are exposed to infected patients or because you work with limited supplies and equipment, as you already learned from previous presentation today. Louis and Reinhard underlined that. If you are infected, you are forced to return to work before fully recovered. You can feel pushed beyond training to treat the unknown, actually. Or you can be forced to work longer, as we all do. The problem is that if you are forced to work longer, despite exhaustion and sleep deprivation, the question is, For how long? And when the pandemic is over? Let's learn more and remember, Lorna, if you are exhausted, the fear of being ostracized by colleagues or superiors for being exhausted, it is a reality. The fear of losing the working place, or the fear of being sometimes stigmatized as possible carrier of the virus by members of the public. This is also the reality that we live today in this pandemic. The last slides about the stressors would be our capacity, both mentally and physically, that at one point ends. So we could lack at one point the capacity to cope with the role that we have as a parent, as a wife, as a husband, as a member of a family. Lack of capacity to deal with a society lockdown, or lack the capacity to recognize the burnout symptoms, or lack the capacity to endure the culture of science of burnout. And that's the reality, because there is nothing around to underline the fact that we could talk freely about burnout in everyday life. The last point about stressors would be, as Reinhard underlined, the lack of system in place to recognize and treat burnout. And what to do? First, we should go and recognize some healthcare ethical aspects connected with the COVID-19 pandemic. And I should stress that COVID-19 has at all levels governments operating in a context of radical uncertainty, as Luis already showed us. The regional and local impact, in addition, of the COVID-19 crisis is highly heterogeneous, with significant implication for crisis management and policy responses. And so, let's try to identify some ethical crises. Luis mentioned already. So one of the core ethical concepts in medical practice is the patient autonomy and welfare. But when you are not capable to offer respiratory support for the patients in need, this principle is critically affected and could lead to symptoms connected and make the healthcare providers with the burnout. Another aspect, these ongoing public health emergencies that COVID-19 created may not provide always enough room analyzing ethical issues for other regular patients. All these other regular patients in this COVID-19 pandemic are put on the second line because the most important thing is to control the infection. Another ethical issue would be, as already Luis mentioned, the social inequities, marginalized population, racial, ethnic, poor minorities. They have restricted access to information and healthcare, and therefore they are much more subjected to be infected and to die because of this pandemic. And the last ethical issue that I would like to underline is the struggle to balance, on one hand, the institutional priorities with the best interests of the patient on the other side. My final point is connected to some potential strategies for burnout. And the key strategy would be first to make healthcare providers aware of burnout and bring to light the recognition of potential burnout. and in addition, to fight against culture of silence. I believe that these are the huge problems in everyday life in this pandemic situation, because we are not able to talk about exhaustion. We are not able to bring up the problems that the second victim caused. And the second case strategy, I would say, but it's kind of simultaneously next, it will be to put in place system for prevention and treatment of burnout at institutional levels. Because we lack totally this system for prevention and treatment. And in addition, to ensure mental health services dedicated to healthcare providers at all times. And nevertheless, to promote positive mental health approach. Here is another subject, but I would like just to mention self-care and mindfulness practices. And to not go over the time, I have just these two short last remarks. I believe that the true psychosocial and epidemiological burden of burnout during COVID-19 is largely underreported, and the medical institutions are unprepared and lack system in place for recognition, prevention, and treatment of burnout of healthcare personnel. Thank you very much for your attention, and the microphone is yours, Matthias.
Monica, thank you very much for your perfect talk, and it shows that we need much more awareness for these psychological factors of work. We have some questions in the meanwhile, but we will have them in the end. So I want to introduce the last speaker of talk number 4, who is Dr. Marco Goeyenbeer. He is from the Netherlands. He studied medicine in Amsterdam and then did a PhD until 2015. And I think, Marco, you are the perfect example of a clinician scientist. It seems to me that you do a lot of research on the one hand, focusing on viral infections and clinical outcomes. And on the other hand, you work in acute internal medicine and intensive care in the Erasmus Medical Center in Rotterdam, and which is in the Netherlands. And your last talk will be about risks and chances for patient care in and after the pandemic. And we all look very much forward to your talk.
Thank you very much, Matthias. So I'd really like to thank EFIM for giving me the opportunity to present during this webinar. So indeed, my name is Marco. I'm a current fellow in intensive care and acute internal medicine. And before I started specializing in internal medicine, I spent a couple of years in the Department of Virology, where I still indeed do quite some research. And I'm associated with the European Scientific Workgroup on influenza. Today, I really like to talk to you about risk and chances for patient care during and after the pandemic. And to do so, I'd like to give you a little bit of insight in how everything moved around here in Rotterdam or in the Netherlands. Probably it's a lot like any other European country or any other country even outside of Europe, but still to actually, when you might think, why is he not discussing this risk, or why is he not discussing this chance? This is what went down simply here in Rotterdam. And again, so I have a background, quite a background in virology, and what happened last year I would never, ever have predicted. So even those and the true experts around January, when the first pneumonia cases and this new virus was reported from Wuhan in China, nobody really know what was happening. And I think the real viral nerds were actually even a little bit excited. New virus shows quite some severe disease in humans. But again, even the biggest experts say, well, don't worry too much, no human-to-human transmission. Maybe you could even still safely travel to China, maybe even to Wuhan, but that was taken back very, very early. Then when the virus moved and was first introduced in Italy, well, we got a little bit nervous, and again, well, not really human-to-human transmission, but maybe some, and only very, very close. And we should think what we will do with patients with the disease that come from China or Italy, not really suggesting local transmission. And then when the virus hit the Netherlands, I can easily say there was absolute panic. There was a lot of, even though we were actually later in the chain compared to the other countries, there was still panic and maybe not even enough prevention or preparation. That was the first wave. Well, as we were speaking, as we were discussing, we're currently in the second wave. I just came down from my day shift and probably go back after this talk again, because we're, as so many other countries, see again a rise of cases, normal care again being reduced, and this everything daily usual routine care changed. So, also because I have the honor to end today's webinar, I'd like to start with one of my heroes, Johan Cruyff, the best Dutch, but maybe even the best football player in the world ever. Who would say in Dutch, elk nadeel heeft zijn voordeel, which is actually translated that every disadvantage has its advantage. And of course, it's very, very difficult and very hard when we're still in the pandemic, and especially after such a real good, inspiring talk about what this pandemic did to all our colleagues and even those that we actually lost. But still, I'd like to end with a little bit of positivity that show you a bit what we've learned from this pandemic. What are the advantages and what opportunities arise from the pandemic? And again, what should we translate towards a post-pandemic world, which we all really, really want to get into? Which chances can we actually take? What is the risk compared to the therapeutic benefit? And if we first start at patient risk during a pandemic, it all starts with isolation. And in the beginning of the outbreak, it's quite easy. So you have these 8 patients that present to your hospital, and they all have respiratory distress. They have a cough, they feel a little bit of dyspnea. Some of them even have a fever. And 3 out of these 8 patients actually have coronavirus. So it's very, very important to identify those 3, make sure they do not get into contact with the other ones, and make sure that you get the patients that are proven coronavirus to actually be isolated on the coronavirus ward. Those that are suspected of a coronavirus but might eventually test negative don't get infected in your hospital. And those that have something else don't get misdiagnosed because you're only focusing on COVID. And these risks change all the time, and they're really, really strongly dependent on the number of infections in society. So it changes whenever there are 5 patients, 5 out of 8 infected, or even when almost everyone presents with COVID. It's really hard to keep a broad view on your clinical picture and your potential differential diagnosis. And again, this is really in the beginning the biggest risk, I think. And I really saw some problems here in the Netherlands in the early beginning. Also when test strategies changes. So first you had a case definition where someone who would actually was suspected of a COVID-19 disease needed to have fever, which would definitely cost subfebrile cases spreading coronavirus within the hospital. And then again, you have the time before your test gets in. In the beginning, of course, it was 24 to 48 hours, meaning that you need to isolate the patient if he needs hospital care within a ward where he cannot infect other patients if he eventually is COVID-19 proven, but he also cannot be infected if he's not infected in the first place, but it's false positivity or false negativity. And then with the introduction of rapid testing, this problem could even be bigger simply because the sensitivity and the specificity of these tests is not that good compared to the PCR. And this strongly correlates to your hospital time and capacity. And I think the capacity definitely is a problem within the group that is a suspected coronavirus case, but not yet proven. And this is really a part where patients can easily infect each other. And then you can also ask yourself, what if clinical signs and symptoms change within 12 hours after admission? Should you reconsider your diagnosis? It's also, should you reconsider coronavirus disease? So there again, isolation is key, triage is key. And I think this is a very big challenge. This challenge can only be brought to a successful end if there's absolute teamwork within the clinician who sees the patient, but also the medical specialists that deliver advanced advanced diagnostics, like the radiologist, the clinical chemist, of course, the virologist or the microbiologist, making sure that diagnosis is adequate but also rapid. Because the hours you have to wait, the hours you do not know if a patient can be moved towards a certain ward or can undergo certain treatment, is time not well spent, time lost. And of course the nurses, which play a very important role in the logistics of all of this and the care of the patients. So biggest risk here in the early phase of the pandemic, of the outbreak, were in-hospital infections, and of course delayed acute care due to capacity problems. Also, in the beginning, we had problems that people could not go to the cardiology ward for advanced diagnostics of their potential myocardial infarction, simply because there were still suspected COVID cases. Biggest opportunities here arise from the implementation and development of rapid test strategy. And I'm not really focusing here on the virus diagnostics rapid test, because of course, it's very interesting, but you can talk for hours on that, and also new methods of rapid molecular detection, but also point of care testing for triage. I mean, this has always been there, but implementation, especially in the Netherlands, was slow, it was expensive, and it might not be sensitive enough. But now we are way more experienced with using cardiac ischemia markers, D-dimer levels, infection parameters, hemoglobin levels, and rapid pathogen detection within your triage unit, showing you direct measurements or within 5 to 10 minutes, and also making it possible to adjust the logistic route the patient will follow. If we then move to the next biggest risk for inpatient care, if we move a little bit on the timeline of the pandemic, and we look to the part where there's a lot of COVID cases and COVID cases increases, normal regular care will actually suffer from COVID. And here it's very important to not miss essential diagnosis. And first essential diagnosis really depends on the pre-hospital factors, and this is on the early presentation of the patients that still come to the hospital. They still come to the emergency department, and of course, if the number of COVID cases increase, if the seroprevalence increases to a certain extent in the Netherlands, where 50% of every patient presenting with fever and dyspnea actually had COVID, I'm sorry. It's very important to not miss other potential diagnoses within your COVID diagnostic street, where everybody is really focused. And I think this is the same picture used earlier today, the tip of the iceberg. But of course, in the beginning, it could be easy, but you need to have the logistics ready to look also for cardiac ischemia, to look for pulmonary embolism, or maybe even pulmonary thrombosis now in the COVID era, where it's simply thrombi arising within the vasculature of the lungs, or pneumothorax. And these are easy diagnoses, but not to be missed in your COVID street, where patients just come in, get their vitals checked, get a swab, maybe get a little bit of lab, and then wait a couple of hours before their test results come in. The essentials should be included here. But there's a much bigger problem and a much bigger spot here for the regular care that's been massively downscaled. And I'm just only naming a few, but psychiatry, of course, plant surgery, oncology, dentistry, cardiology, they suffered major delay in diagnostics during the first wave. And even though preparations and measurements were taken way in advance, definitely also during the second wave. Simply because the number of persons within the hospital and the number of patients on intensive care beds, and also the number of doctors needed to actually treat these patients, would make sure that normal outpatient clinics could not work, could not operate. Operation rooms were empty because they were used for ventilating the severe COVID cases. So you would really miss a lot of diagnosis. And here's such a picture of an emergency intensive care unit within our hospital. And the late diagnosis, there are many manuscripts published on this, but I think this is a very important one, already showing within the first pandemic that there is a massive decrease in confirmed oncology or cancer diagnosis during COVID, which didn't really mean that people, of course, did not get cancer, but it was not detected, and it will be detected in a later stage. And especially the same was published by Din Mohammed for the oncology case, and Marion for the a study in France showing the real increase in later presentation of acute cardiac arrest. And also here in the Netherlands, we actually see a lot of patients no longer presenting with acute cardiac ischemia, but presenting weeks later with heart failure. Then again, another risk, your biggest risk is hospital capacity, presenting yourself to a hospital because you need acute care, but the hospital is overcrowded. And within the first wave, for some reason, everything was, all regular care was scaled down. The hospital capacity was really increased and everybody was looking on COVID. But during the second wave in the Netherlands, everybody really tried to keep the regular care going. And there we actually had a bigger risk for patients for overcrowded, because we didn't really have a general increase all over the countries, but there were these hotspots within provinces. And on this one moment, for instance, the whole southern part of the Netherlands, there was a huge increase of COVID cases. So a patient could actually call an ambulance, get into the ambulance, and the ambulance could just not find a hospital that had any place for him. And of course, this is a big delay of acute care and a big risk for the patients within the ambulance. Biggest opportunity again is the rapid implementation of efficacy methods. A lot of people might not need to go to the hospital. I really like my outpatient clinic, and I really like to see patients. I do it once every Thursday, acute internal medicine outpatient clinic, and I like to see them and talk to them. I'm actually having them physically here within the hospital. But of course, it's completely bullshit when it's a thyroid function check, or just needed to change the way we think and the way we do things. And I think e-health made a huge jump, maybe even thanks to the COVID pandemic. We also sent patients home that were really recovering from COVID-19, but still needed 1, 2 to 3 liters per minute of oxygen supplementation. And they were checked by a physician assistant, also with a mobile application where they could send their vitals and could actually still be checked. So they were still getting this advanced care, but no longer within the hospital. And of course, everyone here, I think, who's still very active in clinical care remembers that large part of your current outpatient clinic is via FaceTime or via safe connection. And if you look at, this is my outpatient clinic yesterday. Normally I would have like maybe five calls, and now it's almost 60 to 70% of even new patients are done by telephone. It's still putting the pieces of the puzzle together. We need to get used to also to get the right patient within the hospital, maybe look into triage possibilities, use artificial intelligence, which patients actually need to be present within the hospital and can actually be very well treated by e-health or outside of the hospital. Also, something we really gained during the past-pandemic is understanding of virus disease, pathogenesis. And this is really something that amazed me, that as per yesterday, when I put the final remarks on my presentation, almost 89,000 peer-reviewed manuscripts were published, which is over 200 a day. And of course, there were also many of them that were published because of the hype, and some of them you could really debate the quality, but especially the past 2 months, quality has been really high. And this is because every researcher is a COVID researcher and everybody is working together. Comparable, still no influenza, but influenza we know already for a very long time, and there are 138,000 papers. One of my favorite viruses, the hantavirus, only has 4,500 viruses. And to put it a little bit in perspective, the last public health emergency of international concern, Ebola, only has 9,800 papers in total. So this is like really amazing. And again, every oncology scientist, every cell biology scientist, they're all working on COVID now, which also gives massive new insights on technique, on understanding disease and disease severity. And one of the things I found most intriguing from the past months is this image of hyperinflammation, and also the return of immune suppression in the treatment of infectious disease, and the essential timing of it. And in the past 20 years, there were many hypotheses about corticosteroids in severe respiratory infection, but timing always was a problem, and also the power in your clinical studies. And thanks to the pandemic, power is no longer a problem. Immunothrombosis and different kind of thrombosis, and also looking at thrombi within a microscope, explaining that there are different ways a thrombus could actually form. The epithelial-endothelial interaction, comorbidities and disease severities, and they also show you a lot about how viruses work and how viruses make you sick if patients with certain underlying comorbidities have way more severe disease, which goes way beyond only a lesser condition. And tailored medicine. And this is something also done to 2 large groups in Europe show, for instance, your ex vivo potential of your monocytes, your ex vivo potential of your neutrophils, which could tell you way more of individual cases rather than leukocyte count or CRP count, which is basically the average of a large Caucasian wild male population somehow decided that if you have a CRP above 20, you could have a bacterial infection. Could be way more interesting eventually to have like a library of what your healthy potential of a monocyte and what happens when you enter the emergency department. And also the insight of acute respiratory distress syndrome, severe ARDS, some of the many CT images many of us would have seen during the past pandemic. And if you would have shown these pictures 2 years ago to an intensive care specialist, he would say, put him on ECMO and wait for a lung transplant. But now we also know that you can actually recover quite well from these severe images. Of course, we do not know long-term effects, and we do not know if they ever get over this fibrosis, but they survive. And we also know that specific treatment, and I saw some recent preliminary data of the REMAP-CAP study also showing that tocilizumab might have a role in these severe ICU cases. And I think that's very, very interesting. So to wrap up, for science-wise, what's my, not sake of time, not a top 10, but some of the top things. Well, mRNA vaccines. I got still a painful shoulder from 3 days ago for my first shot. I think it's amazing and almost unbelievable that 2 years ago we're looking at a Nature paper on primates, and now it's phase 3. No, not even more phase 3. Now it's already being given to healthcare workers in the Netherlands, and in other countries they're already way further in vaccination strategies. The reuse of immune suppression and the timing of immune suppression, tests, but also rapid nucleic tests, so PCRs without amplification. So increasing your diagnostic accuracy and definitely pace within the emergency department. The potential of a lower respiratory tract virus without pre-existing immunity. So of course it's COVID-19, and of course it's to some extent SARS-CoV-2 specific. But I'm quite sure that if you would take a very strong influenza virus, a very virulent influenza virus, and put it in the lower respiratory tract of someone without any influenza pre-existing immunity, you would see about the same clinical picture you see right now. It's just that it's so big now because there's no pre-existing immunity. And again, you also see the potential of masking and social distancing. And there's a lot of debate and a lot of studies now focusing on the COVID-19 pandemic and the effects of masking. But then you must understand that you started your intervention on the absolute peak of the pandemic. And also there were done so many interventions at the same time. I think it's way more interesting to look at past season and look at the number of influenza cases, look at the number of RSV cases, HMPV, or hardly none. RSV in kids, hardly none in Europe. Influenza, not a severe season. And that's simply because masking and social distancing works if it needs to be done. And the other one I personally find very, very interesting is that the healthcare attitude towards vaccination changed drastically. Originally, I was supposed to give a presentation in April this year on the Dutch Internal Medicine Days about why in Dutch internal medicine specialists, the vaccination rate of flu shots, of influenza, yearly flu shots, was only 55%. And I needed to convince them, based on hard scientific data, why getting your flu shot was actually a good thing and why it was good for patient risk and nosocomial infections. And now we move actually from a completely different attitude where these are only some of the pictures, but on social media, LinkedIn, there are huge campaigns of saying, I want that shot. And even our most famous general practitioner in the Netherlands is used by the government on posters towards the country saying, I get my shot. So also healthcare work attitude towards prevention and towards nosocomial infection, absenteeism, which is also, I think, a big problem. Normally, when you wake up, you have a little fever and you have a cough, thinking, I need to go to the hospital because I need to help. No, be aware of your own risk you can give towards patients. Of course, there are also challenges, and I'm going to wrap up also on the sake of time. Early and accurate diagnosis here is key. It would be best if a patient walks in the emergency department and within a couple of minutes you would know if it's a COVID or not, or it's any respiratory pathogen. But eventually we need to go to combined respiratory panels, because now we're so focused on COVID-19, because I'm really afraid that once there is another pathogen also there, now a patient presents with cough, with sneezing, so being very infectious, but he gets a negative COVID-19 test. He's moved outside of isolation in many cases. But when he's still infectious for influenza, he could infect the whole hospital. And a severe influenza outbreak is also really, really something you do not really want. one-shot treatment, antivirals and or antibiotics. And I think these are very interesting also for patients that you do not really want to admit yet, also maybe because of a capacity problem, and you think you can send them home with adequate monitoring, maybe even some oxygen supplementation, but you want them to be covered for the most severe complications like sepsis or severe viremia, probably with the combination of a third-generation cephalosporin, aminoglycosides, and a one-shot antiviral treatment rather than 5 days oral Tamiflu because of compliance, and really make sure that you can think of a way of a measurement to not get returning patients. Also, we could better even look into safe discharge source and go on, because a patient that returns, of course, is again someone that needs to be isolated, because a test 48 hours ago will not protect him for having COVID 48 hours later. Also, something I think that's really challenging is the actual usefulness of antibiotics in severe COVID-19. Worldwide, we're using a lot of antibiotics, and I'm not really sure if they're any useful, and if they're not might even be harmfuler than we actually think. Keeping up routine care is the biggest challenge, but we all know, and a potential collision with a severe flu season next year. I hope we're done with COVID when the next season comes. So benefits. Vaccine uptake has never been so high in healthcare workers. mRNA vaccines, I'm just so enthusiastic about them. I can keep talking about them. E-health, the implementation of eVal. Targeted immune suppressing and timing in infectious disease. They're back on the table. Maybe even activated protein C treatment in sepsis can come back, because timing is key in every individual. You need to know where they are in their infection kinetics and dynamics, how much virus is still present or is the virus already done. And then you need to interfere. And I think that's going really well for now. It's teamwork, and to continue with this nice, really real picture from Gartner consultant. First, we respond. We're still trying to recover, but we're also responding now to the second wave. And eventually, we would really need to renew. And I think there's an essential role also discussed by previous speakers today for the generalist or the internal medicine specialist. I'd like to thank you for your attention and give the microphone back to the moderators.
Thank you very much, Marco, for your very nice talk. I would like to invite all panelists to open their screens and to open their camera. And I would like to start the discussion. And we have four questions in the Q&A. And I think the first one is probably for Reinhard. The question is, what is the percentage of suicide in healthcare workers in the pandemic? Do you have any more precise data on this?
So it's a simple question and a short answer, with greetings to Peru, where it's asked from. No, we don't have any data yet. So we expect data on the suicide statistics for Germany in August 2021, which is a normal delay. But we have to guess that a lot of healthcare workers are at risk right now. So we knew from the SARS pandemic in 2003 that 50% of all healthcare workers involved in the care of the patients had signs of post-traumatic stress disorder or burnout. And we all knew that post-traumatic stress disorder and burnout increases the risk for suicide. So right now, the discipline, the specialty with the highest suicide rates among all medical disciplines is my discipline, the anesthesiologist, which has a 6 up to 8-fold increased risk for this. But I guess this will change, as not only anesthesiologists, but also specialists in internal medicine have to treat COVID-19 patients. So I assume that this will rise, while the general suicide rate might even drop down because of the home office, increased home office rates, as the work might not have such a big influence on the persistence of diseases. And also, being second victim and committing suicide is not only an acute symptom like Monica told for Dr. Breen in New York, but it can also be a development that lasts about 6 up to 12 months or even a couple of years. So I'm not sure how this will end up, but of course there's a need to prevent now and to invest in mental health for healthcare workers, to not only to keep the system stable, but also to keep the healthcare workers safe. So we need a psychological PPE as well as the physical PPE. And we will see how this rate will increase, but my hope is that it will not increase because we take active measures and we take the chances to be more aware of this phenomenon.
Reinhard, do you think it's more a cultural or more a financial problem to bring more measures into practice, like
I think
for prevention?
it's primarily a cultural problem because, so I'm a doctor, I'm an anesthesiologist, I worked at a university hospital. So the patient is the one who's ill. I'm not the one who's ill because I'm the doctor. So at some stage, and I can point this from my own, I was bulletproof, or I thought I was bulletproof. So I think it's a cultural thing to acknowledge that we have a problem like every other human being has a problem with this crisis, that we can be mentally affected. And it's not a sign of weakness, but a sign of professionalism to seek for help. And so from my point of view and all the colleagues I know, doctors are not the best patients, but doctors are doctors. So I think it's a cultural shift that's necessary. But as this is a collective experience everybody faces right now, not only in the healthcare sector, I think it's adequate to talk about the own implications this has for everybody, not only the ones staying at the intensive care units, this pandemic. So I think changing the culture, and to answer another question that is raised, setting the awareness within the departments, not only to do mental checks, external mental checks, but to create a culture of support and sustainability among healthcare workers itself will be the most effective measure to prevent from second victim traumatization, as evidence suggests from all centers that have implemented such programs in the previous years.
Maybe, thank you, Reinhard. We go on with another question from the Q&A. Monica, the person who asked question here suggests that it might be helpful to have like now and then a phase off from work, from direct patient care. Do you have some advice on this? If this could work, or if it's advisable?
It could work, of course. Maybe it is the best for the one in case, but thinking at the crisis that healthcare systems are facing right now, I think that no organization will approve that one of the healthcare provider that they think that is available to work would be allowed to leave the work. So yes, it is absolutely a solution to try to treat the burnout in a very, very professional way, but we lack actually guidelines for that, and we lack systems in place. So first of all, as I mentioned in my presentation, we would need to recognize the problem globally, and then we will stay together to create a guideline that will help us all to survive and to not experience the same as our colleagues that are not among us today.
Thank you.
Reinhard has something to say.
If I may add something.
Please.
So you probably be aware of the Geneva Declaration of the General Assembly of the World Medical Association, which can be regarded as the new version of the Hippocratic Oath for medical doctors. And if you look at this declaration, it says, I will, and I quote, I will attend to my own health, well-being and abilities in order to provide care of the highest standard. And I think we have to reinforce this in order to make colleagues aware that we also are human beings and we don't have to be superheroes. And if we care for ourselves, and if we take care for ourselves and invest in our self-well-being, when not while staying outside the hospital, I think it should be also an investment that it's not only an investment for our personal health, but also for our professionalism, to reduce medical error and to keep our patients safe and to treat them professionally. So I think we have to reinforce this, as this is common sense of the World Medical Association. But to be honest, you can easily say this, but it's harder to do this. But I think just in these times, when the capacities run out, when you don't have time to do things, or you think you don't have time to do this, as Mahatma Gandhi quoted, if you want to achieve a goal very fast, take a break. So you have to take a break in order to achieve these goals, and you have to invest in your self-well-being. It's not selfish, it's not unprofessional, it's the other way around. And we have to keep this mantra to our colleagues.
you. And maybe before going on with the Q&A, I have two questions, one for Marco and one for Luis. Just to start with Marco's question, I really wonder what is his experience on the rate of hospital, the nosocomial infections. So, for example, looking at the hand hygiene or other infection control precautions, what has changed with the pandemic? So we really have an advantage here, a room for improvement through the pandemic, just to settle down our habits in terms of hand hygiene and PPE use and so forth. So what's your observation during the pandemic about nosocomial infections?
Well, to be honest, I think that the number of nosocomial infections, or really the doctor infecting the patient, wasn't that high. Because the isolation in that way was relatively easy. Once you had patient contact, you would wear your PPE, or you try to wear your PPE, and of course sometimes things went wrong. But then again, I don't think that that's the biggest problem. I think that the biggest problem here, and that's also been investigated and I think already published, there's also some reports from Rotterdam itself, that there were clusters of colleagues infecting each other. And of course that's then a big problem, because then you get a lot of colleagues at home sick, and the quality of care goes down because you have to do it with less doctors. I think that really was a problem, especially also in our resident groups, that we had periods within the pandemic that we had a high dropout, and it was all clustered and very close. And genetically, by phylogeny, some virologists did some experiments on samples from colleagues in Erasmus, showing that they're actually from the same clade.
Yeah, and actually I was also asking about the multi-drug resistant bacteria, for example, aside from the nosocomial COVID cases, because what we have observed in our hospital was the precautions and increased hand hygiene resulted in a very sharp decrease in the rate of other hospital infections.
No, with that I absolutely agree. And I think that's something that I will put in my presentation if I have to do this talk ever again. But I think that's also something really gained, because I think the number of nosocomial infections might even went down. Also because it was way stricter that when a healthcare worker was sick, you would stay at home. You will wait until you get tested. And now we're only looking at COVID, but still you'd stay at home for 24, 48 hours. And we have such a drive to come to work. We think nobody can miss us. We need to be there. But we're actually, once we're there, while feverish, while infectious, we're a danger for our patients. We're not helping anyone.
You're right. Okay, thank you. And just a question for the future prospects to Luis. So, for example, last year in the Lisbon Congress, I remember that Reinhard was talking about the decrease in the number of beds gradually. This was planned to increase the number of beds in the hospitals throughout Europe. Luis, do you think that the future will be different that we have what we have expected before? So we have seen that the flexibility of the hospitals is not enough to fit to the demands on the pandemic. So do you think that the hospitals, the governments will change their plans in terms of organization and the healthcare system planning?
Well, the answer is maybe yes, maybe not. It depends of our capacity to learn with all these lessons. What I think is that there were many things we were in the wrong direction. The scarce, the reduction of the health professionals, the fragmentation of care, the reduction of beds, the small number of intensive care beds, a small number of ventilators. All of these came out during the pandemic. So there is a huge opportunity to change this. But to change this, you have to have leadership. And you have to have all the people together in order to reform the health. And that is not easy, because in many countries like our countries, there are political equilibriums that are very fragile, and these deep reforms that we need sometimes they cannot be done because of these political balances. But yes, I think that we should learn and reflect about all the things that are happening in hospitals, in primary care, long-term care. The social assistant is so important, this connection with social assistant. Around 20% of our patients that are in the hospital, they are there only because of social problems. So if there was this connection and this integration, we could put them outside of the hospital. If the primary care doesn't collaborate to decrease the number of emergencies that come to the hospital and see the less acute patients, well, the hospitals will not be capable to accommodate all this. So everything is connected. Everything should be a system. Everything should be managed together with the same budget, with the same leadership, but that needs courage, needs leadership, and needs to be a political priority by our governments.
That's right. Matthias?
Luis, maybe just one very final and last question. You spoke about the human resources, and in Germany it became clear that the most precious resource were the nurses. And I just were asking myself, it's the same in other European countries. We had such a shortage of nurses that we couldn't run like wards, new COVID wards, because they were missing.
Well, I think that are the nurses, the doctors, and the people that does the cleaning, and the people that makes the transport. Everybody, all of these kind of people were short in our health systems. In Portugal, for instance, most of the COVID patients are treated by internists. My department is all treating all the doctors there are treating COVID for 10 months. So it means that my residents, the people that is specializing, it doesn't make the formation, the education as before. It is very interesting to treat COVID patients during the first 3 or 4 months, but after that, they have to see other things. So, and it's hard to go in the COVID ward to dress all the PPE and to be there for several hours without drinking water, without going to the toilet, to deal with all these patients that doesn't receive visits and are alone, to deal with the families that that don't have news from they don't see the patients. Everything, we have the perfect conditions to increase the burnout of the people, and 10 months is too much. And really the management, the politicians are not aware of this. They don't have this concern to rotate the people, to rotate the doctors, to put other specialties helping all in this care. So I think, yes, nurses are very, very important, but also doctors, and we internists are suffering a lot. But as this is the last question, I would like to finish and to thank you in the name of our Quality and Professional Issues Work Subcommittee of EFIM, and to thank to you, Matthias, and to Monica and Min for organizing this webinar, and also the support of Delta Medical Communications, and also to Reinhard and Carlo that presented these talks. I think your messages were very important, very very interesting, and very accurate. The only message that I didn't like was from Marco saying that Cruyff was the best player in the world, because I have another opinion. I think is Ronaldo, but all the rest was very very important. So I wish you courage to face the near future, because we have to have a lot of courage. We don't know what is coming, and it can be worse than we are living now.
Okay, so thanks a lot for all of you for being with us today, to the audience, to the distinguished speakers. So actually we can talk for hours and discuss for hours. I also have some other burning questions as the audience, but we will email the answers to the unanswered questions to the participants. So thanks a lot, and I hope to meet face to face in the very near future, hopefully. So the keyword is hope. We all hope for the success of the vaccines and the end of the pandemic. So thanks a lot, and see you later again. Bye.
Bye-bye. Thank you very much.
Bye.